கனகவேல் ரெக்கார்டிங் ஆயிட்டு இருக்கு. Prashant sir.
Yes.
Yeah. Very good evening, sir. Sir, what can I tell you about it?
Pardon?
It was dissemination, sir. Just resume 2 lines.
I am laparoscopic and colorectal surgeon.
Yes, sir.
And at present I am president of International Society of Coloproctology.
Yes, sir.
ISCP. And I am CMD of 7-Star Hospital, Nagpur.
Yes, sir.
Organizing secretary of 2019 Natcon.
Okay, sir. Sir, currently you are in?
I am in Nagpur.
Nagpur. Okay, sir. Nagpur, which hospital, sir?
7-Star Hospital.
So, President of International Association of Coloproctology, sir?
ISCP, International Society of Coloproctology.
Yes, sir. Thank you, sir. Thank you very much, sir.
Thank you so much.
Kanax recording போட்டாச்சு.
Yeah.
வேற என்ன co-host பண்ணணும்? வேற என்ன technical?
That you are going good, Kannan sir. அவங்க எல்லாம் வந்துட்டோம். Then you can start.
Yes,
Anyway,
sir.
Prashant sir is now here. You are there. I think Niranjan sir. Now it is 3:50. By 4, all of you will be there.
Yeah.
The issue is, moment we start the original session. Now you can stop recording. Moment you start the original recording, please clock it for 42 minutes.
Okay.
So 42 minutes, please about 2-3 minutes before, please inform Niranjan sir, and that should be the last question.
Okay.
Because 42, maximum 43 minutes, not more than that.
Okay. Because Jayalal sir on the Kanyakumari Medical College, isn't it?
He is the president, national president-elect IMA, professor of surgery at Tirunelveli Medical College.
Tirunelveli, okay.
Kannan sir, he may not join.
Okay, no problem.
I think they are busy meeting with the health minister for the program, inviting the program.
Okay. Jitendra Chaudhary, professor in Tripura. Kanax, do you know anything about Jitendra? He is professor in Tripura Medical College, right?
One second. I will give you the information. He is Jitendra Chaudhary.
Ama, Jitendra Chaudhary.
Jitendra.
D-U.
Yeah.
Okay.
And sir,
Yes.
what will be the plan now? You will straight away start the session
Yes.
because I will do the introduction during the main conference lively. Okay.
Okay. Okay. Okay.
I will be standing by if there is any challenge. But you please conduct the program.
Okay.
Maybe if you want, you can call Kalivani madam, and all of their numbers are in the WhatsApp group.
Yeah. In another 5 minutes, I'll call.
Because if you call, then you will be able to save time.
Yes.
I have another recording at 5 o'clock, sir. So please help me.
We will finish by 4:40. Okay.
Yeah, we have the Indian Association of Surgical Oncology doing breast cancer panel by 5 o'clock.
Okay. Okay.
Thank you, Kannan sir. I will be in mute mode. If there is anything, call.
Okay. Hi, Rashekar. Very good evening. Can you join? Yeah, 4 o'clock, but everyone is joining. In few minutes, you can join. What can I tell about you? You are professor of surgery in Mangalore. What is that? K.H. Hegde. Oh, okay. K.S. Hegde. Medical Academy. Professor in General Surgery. Okay, thank you.
Yeah, Prashant Bhau.
Sir, Professor and head, right? Okay. Thank you, Raj. Please. Bye. Sir, good evening, sir.
Good evening. How are
Yes,
you?
sir. Yeah, fine, sir. Fine, sir.
All well?
Yes, sir. Everything okay, sir.
Can I share my slide and see?
Yeah, please, sir.
Niranjan sir, good evening. Dr. Kannan will be doing the recording, sir.
Yes. Thank you.
Thank you, sir. Thank you, sir. Thank you.
Kannan,
Yes, sir.
you disabled participant screen sharing. Please allow.
Connects. Screen sharing facility. Connects. Yeah.
It's still
Kannan sir, 1
disabled.
second, wait. Kannan.
Yeah, no problem.
This had an option. It's like, do you want to continue? Yes.
Kalivani madam, good evening.
Good evening, sir. Hello.
Madam, nice meeting you.
Nice meeting you.
Good evening, ma'am. Dr. Kannan, ma'am.
Good evening, sir.
Good evening.
I'm from Ramaya Medical College.
Yes, ma'am.
Hello, sir. Dr. Prashant. Dr. Prashant, yeah. I am Dr. Kalayani from Ramaya Medical College. Hello, sir. Dr. Niranjan.
Namaste. Nice to meet you, ma'am.
Yeah, same here, sir. It's an opportunity to meet everyone.
Yes.
You're from which place, sir?
Our two friends from Chennai are very active in all over.
Yes, true. That's true.
Thank you, sir. Thank you for your compliments, sir.
Niranjan sir, try sharing the screen now, sir.
It is still showing disabled.
Sir, I've enabled, sir. Please try, sir.
Okay, yeah.
Kamal Gupta, sir. Good evening.
Yeah, good evening to you, sir.
Yes, sir.
Good evening, Kamal sir.
Sir, excellent, sir. Sharing now, sir.
I think you are good to go. You please wait for Deependu sir to join. I think all
And
others are.
Rashir also join in
Rashekar
few
sir
minutes.
join.
Dr.
Yes.
Prashant, good evening. Nice to see you.
Good evening, sir. Kannan sir, I'll be in mute mode. You please handle
Okay.
this.
Okay. Thank you, Kanex. Thank you.
Dr. Kannan, am I audible?
Yes, sir. It's audible, sir.
Thank you.
1 hour disturb.
So my panelists saw the cases which I sent in the WhatsApp.
Yeah, Nandya bhai, we have seen it.
Very nice. अरे ये कोट और टाई के नीचे क्या पहना है कमल?
He is in his suit.
Get up now. Boss, I am sitting in my office.
कि
भाई आपकी ना वो बात नहीं जाती बदमाशी वाली है.
वर्चुअल मीटिंग की ड्रेस चेंज हो गई सबकी एक्चुअली.
हाँ.
ड्रेस कोड चेंज हो गए.
नहीं देखो डॉक्टर प्रशांत बैठे हैं ओटी के
Good evening, good evening, Rajshekhar. Good evening.
So, professor is here.
Yes.
Welcome, professor.
Thank you.
Dr. Rajshekhar, good evening.
Good evening, Kamal.
Dr. Kamal sir, good evening. I'm Dr. Kalevani.
Yes, ma'am. Yes, ma'am. I know very well.
Dr. Rajshekhar sir, I'm good evening.
Good evening, Dr. Kalevani. Dr. Prashant.
So,
Hi.
just a few words before we start. These are mainly a general practitioner audience which is expected. So we have to talk from basics things, keeping them in mind. You know, not many surgeons would be logging in, so it will be a generalized talk. You know, it won't be a surgery specific or procedure or literature specific. How best to guide them what to do when a patient of suspected hemorrhoids come to them.
Okay, sir.
Thanks, sir.
I think, sir, Dr. Dityendra Chaudhary is not a giant, sir.
Kannan, should we call him because it's already 57?
Yes, sir. I'll call him.
Oh, anyway, it's recording, so it's all right. Otherwise, if it was live, then it would be delayed.
Yes, sir. I'll call him, sir.
Rajshekhar, your mic is all right, no? Didn't hear you.
Can you hear me now, sir?
Slightly louder. Or get the PC closer to you.
Yeah. Now is it better?
Yeah, much better. Prashant, your mic? You are muted.
Yeah. How is the voice?
Yeah, better.
Yeah.
Okay.
मैडम को तो सुन लिया हमने.
You're from which call? Which
Kannan, have you
sir?
called him? Sorry, ma'am, you were saying something?
Are you from which place, sir?
I'm calling him, sir.
Your voice is not clear. Can you
No,
come?
I just asked, you're from which place? I asked you.
Okay, I'm from Mumbai, ma'am. I'm attached to Bombay Hospital.
Okay, sir.
And Dr. Prashant Rahati is from Nagpur. He is owning a own 7-star hospital,
Oh,
which is actually a
fantastic.
7-star. I mean, the name, not only the name, the grading is also 7-star.
Okay.
Then we have with us Dr. Kamal Gupta in Sud Boot. He is from Jalandhar. He is the laser man of India.
Hello, sir.
He owns a hospital called Karan Hospital, which is a teaching center for minimal invasive proctology. And Dr. Rajshekhar.
This is Dr. Kannan speaking, sir.
Dr. Rajshekhar Mohan is a professor of surgery at Mangalore.
Bangalore.
And ma'am is a professor of surgery at Ramaya Medical College, Bangalore.
Bangalore.
Hello, sir.
So it's just a replacement of M and B.
Okay. Yes.
Yeah, ma'am, we were there at Ramya Medical College last year. There was a conference, you know, on laser proctology. I had come along with the
We had organized, yes, sir. We had organized a CME and come workshop.
Yeah, I was there along with Dr. Kushal Mittal at that time. It
Yes,
was a part of a cursing only.
There is a life form behind Dr. Prashant Rahate. Yeah. Comes and goes.
Virtual background.
Yeah, the virtual background is funny actually.
And Niranjan, there was a, you have put up one slide. Hello.
हाँ सुन रहा हूँ
Regarding that surgery is needed for the job.
Yes.
Is it true?
I didn't say surgery is needed for the job. I said he wants a fitness, because many times you see we get a lot of patients who are wanting to join Navy and all, and then clinically they have got some piles which are asymptomatic, and then the medical officer there turns them off, you get a fitness or get them treated. So
I have heard of some varicocele, hernia, hydrocele, but not about the hemorrhoid. They do proctoscopy during their exam.
Sir, excuse me, sir.
Yeah.
Sir, Dr. Dr. Chaudhary has held up in the traffic, sir. It may take another half an hour also.
Half hour?
Half an hour, sir. He is in the traffic. It is horrible.
What should we do?
He can join on mobile, no?
He can park the car on the side and join by mobile.
Okay, sir. I think he is driving. That's why it's difficult. I think so.
That's why I said park the car on the side.
Okay. Sir, can you tell him, because he told me it's not audible.
Dr. Kanagavel has to take the decision. There are 6 people who are logged in. So Prashant, coming back to that, these are all money-making things by the officers on duty there, They will scare them, they will ask them for certificates, otherwise they will give them certificate, all those kind of things.
Is it legally needed?
No, their fear is because in the midst of the sea, if there is a patient who's carrying a disease and he falls sick for some reason, then what they will do in them, because once the ship goes into the sea, they don't come back for a month or so, So,
sometimes they are off the shore for 6 months.
Yes, exactly. So that is why they are extra careful, and all that we need to do is to tell them that they don't require surgery, Basically, we need to give a certificate to them.
Okay.
Sir, I think he will call you, sir. I think he could not be able to join.
So what is the decision? Are we waiting for half an hour like this?
No, sir. But better we can proceed, sir. Since we are having 4 panelists.
Sir, அவர் சொன்ன மாதிரி மொபைல்ல ஜாயின் பண்ண சொல்லுங்க சார். Kannan sir.
He told me that he is not able to hear anything.
He has to go to a place where there is signal.
Kanagavel?
He's missing.
Sir, I think we can proceed. Kanagavel?
I think he also is logged in and doing some other work, huh?
No, sir. He is coming from Madurai to Chennai.
Oh, Kanagavel himself?
Yeah.
Okay.
No problem. We will proceed, sir. I'll just call him and then he'll... Just 1 minute, sir.
How is it in Mumbai, sir? I think there's lockdown and a curfew, I was told.
Don't get carried away by any newspaper.
Nothing, sir. Okay, it's all casual going on.
It's fully functional. People who don't want to give money say lockdown.
Okay. That's true. That's true. Here also we see everything as casual as ever.
And I don't think the cases are actually going down. They are being underreported.
Yes, sir. Yes. People have become a little casual now.
Yeah. And they are also kind of not doing
Sir?
proper things also.
Excuse me, sir. Sir, I told Kanagavel, sir, we can proceed, sir, because It takes another half an hour to 1 hour to reach the station. So we can proceed, sir. Actually, this is morning program. So shall I start with good morning, everyone? Like that, sir?
Yeah.
Yes, sir.
So just tell them so that they also know it's only being recorded and it's going to be played on a Sunday morning.
Yes, sir. Yes, sir.
We'll be logging in that time live, correct?
Yes, sir. Yes, sir.
But we don't have to talk that time till the program unless there are some chat questions which comes up which we are supposed to answer.
Yes, sir.
Right? No?
Yes, sir. Exactly.
As I earlier said, most of the delegates are would be general practitioners.
Yes,
so
sir.
our answer should be according to the general practitioner segment.
Yes, sir. So it's a 40 minutes program, sir. So
Yes.
after the introduction, you can start the panel discussion, sir. So last 3 minutes, I will give you the timing, sir. So you can finish the final question.
Fine.
Yes, sir. Shall we start, sir?
Please.
Yes, sir. Very good morning, everyone. We are having the great moderator and as well as the eminent panelist here to discuss about everything about the hemorrhoids. We are going to know about the reasons and the clinical managements and the complications and as well as expert management of each and every situation of the patients. Here we are having Dr. Niranjan Agarwal, none other is the president of Association of Colon and Rectal Surgeons of India, and also he is a surgeon in Bombay Hospital and Salazar Nursing Home and as well as Wakadat at Zen Hospital, and he is the executive board member of International Society University Colon and Rectal Surgeons. And here Dr. Prashant Ragate is the president of International Society of Coloproctology. Currently, he is having the 7-star hospital in Nagpur. He is a leading laparoscopy and colorectal surgeon. And the another one, Dr. Kamal Gupta, is a laser man of India. He is owning training center as well as deputy center in here, and he is doing a lot of work and he is training a lot of youngsters in the country, and many of them now that take this laser as a specialty, especially in the coloproctology. And Dr. Rajshekhar is a professor and head in KS Hegde Medical Academy, Bangalore, and Dr. Kalaivani. She is professor and head MS Ramaya Medical College and also chairman of Bangalore Surgical Society. Now, sir, this ball is in your court. You can start, Professor Dr. Niranjan Agarwal, sir.
Good morning, Kannan and
Yes,
Dr. Kanagavel. Thank you to IMA for giving this opportunity. We have got 40 minutes to discuss about hemorrhoids today.
Yes,
hemorrhoids, as all of you know, are symptomatic enlargement and distal displacement of the normal anal cushions. They were referred to as dilated vein, which were related to the anus, derived from the word hem meaning blood and rus meaning flowing, or called like a ball, pila meaning a ball in Latin. Interesting is to know that more than 50% of the people over 50 years of age will have suffered some or the other attack of piles in their lifetime, and equally common in both men and women, and having a tendency to run in families. Fortunately, uncommon below the age of 20 years. It forms a major chalk of practice for the general surgeons also, but the GPs are the first one to see them in their history, who mainly evaluates them only on a history, because the resources for an examination, rectal examination in their GP clinics are limited, and most of them it is missing. So all bleeding PR are invariably called piles by the patient themselves also, and they are treated as such with some kind of the creams which I just mentioned and whatnot formulas which are being propagated by the medical representatives. However, proper evaluations would help in decreasing not only the morbidity but also mortality, because all bleeding PR need not be hemorrhoids. So to discuss this hemorrhoids, I am here with you today in this panel discussion on hemorrhoid at the IMA Natcon, and my compliments to the organizers for having this panel discussion, an important topic. Myself, the moderator, already been introduced by the Dr. Kannan, and these are my panelists, eminent panelists from all across the country who will be deliberating. So to start with, Madam Kanagavel, can you tell us what are the theory behind the hemorrhoids and what are the other precipitating factors? Briefly, can you label it so that the delegates know about it? Madam?
Sorry. Yeah, can you hear me, sir?
Yes, yes.
Yeah. So basically, we say the causes, the general public thinks of the cause being constipation. However, constipation is only a precipitating factor. But the basic theory is the rectal mucosal prolapse and the rectal descent and lack of support in the submucosal plane. The theories that has been proposed. And also because of the lack of, there is an increase in the blood flow in these dilated, the inferior hemorrhoidal arteries, and they are dilated, and there is an increase in the flow is another theory that is being proposed. And so the new treatments are also based on these new theories. Precipitating factors, as I said, lack of fiber, and so constipation and other factors like obesity, then pregnancy and cirrhosis, etc. These are the conditions which can precipitate the existing pathology that happens here.
Kamal, would you like to add anything other than this? Kamal? Dr. Kamal Gupta? Is he logged out?
No, sir, he is in. Just see the panel.
Kamal.
Kamal, sir.
Okay, Prashant, you can add if
Sir,
anything.
actually, he is, sir, Kamal, sir, you have to unmute. Unmute. Yes, sir.
Yeah, Dr. Nanjan, sorry. Dr. Nanjan, basically all the theories have been mentioned by Madam, but I think the latest theory which we should add is of hypervascularization theory, which has been given by Eigner in 2006. Before that, whatever theory we had, that was in 20th century, but I think 21st century, only one theory has come, that the increased in vascularity may be because of increase in caliber of the blood vessels, that is superior mesenteric artery, superior rectal artery, which is supplying the anal cushions.
So the most important point to note, it is not only a venous disease what it was being propagated earlier, but it has got an arterial element to it. Everybody should know that. And then to rush through it just so that the discussions can happen properly, I can tell you there are two types of hemorrhoids, the external ones which are outside the anal margin and the internal ones which are inside. And depending upon their level of prolapse, they are divided into 4 grades, that is 1, 2, 3, 4. If it is the piles remains inside the anal canal, it is grade 1. If they come out and go back inside spontaneously, they are called grade 2. And if you have to, the patient has to push it back after they come out, they are grade 3. And the grade 4s are the one which continuously remain outside or are complicated. I said all these things so that the treatment will be according to that and we can learn from this. So coming to Prashant Rahate, how do you diagnose this patient in your OPD? You know, when they come to you, usually the patient talk about I have piles. They don't even tell you the symptoms, you know, they give you the diagnosis. So what would you do in your clinic so that you can diagnose that it is only a hemorrhoid and nothing more than that? On history mainly, before the exam.
Yes, the history is very important, Niranjan, here. That history itself can give you some idea what is happening there, because the patient, whenever the blood comes out, patient say that it is piles. And many a times it is not like that. So we have to take proper history regarding the occupation of the patient, diet of the patient, and the working pattern of the patient. Then what type of bleeding it is coming, whether there is pain or no pain, whether anything is coming out of the anus, that is to be discussed with the patient, and if there is any mucus, itching, all these things are to be taken in properly noted in the history, and that is more important. And we have to see in history whether there are any complications also, whether the patient has fever, any pus discharge, or there is any loss of weight, considering we think about the malignancy or like that. Then whether the stools are mixed with the blood, or the blood is coming independently before the defecation or with defecation or post defecation. All this history is to be judged properly, and that is the crux of the clinical examination. Then we go ahead with the clinical examination.
Rajshekhar, any points to add? How would you differentiate with other differential diagnosis? Or you can enumerate what would be the differential diagnosis and then tell my delegates how would you differentiate with each on the history, because examination of proctoscopy, etc. in a GP clinic is fairly impossible. Maybe they can only open up the buttock, retract the buttock and just see. Inspection is all that is possible, or at the most palpation. Proctoscopy and all, I don't think it is practical for them. Though ideally it should be done, I don't deny that. It has to be done. So Rajshekhar, would you add to what Prashant said?
Yes, sir. I would want to say that sir has covered everything. It is important that in the general practice clinic or in your practicing clinic, we need to differentiate the cause of bleeding from intestinal cause versus an purely anal cause. So if it is due to some intestinal or intra-abdominal cause, you would have other symptoms of abdominal disease such as abdominal pain or pain which is followed by passage of stools with blood, some signs of bowel obstruction if it is a tumor that is a cause for bleeding. So these are very subtle signs, because patient will tend to usually ignore these small differences in their bowel habits, and they would come and say, I've got bleeding, and everything that is associated with bleeding is piles. Now within the anal canal, we could also have a fissure, which usually results with a streaking of the stool. A line would be forming on the line of blood on the stools, or after defecation, painful defecation followed by a few drops of blood. That has to be differentiated from the spurting activity that you would see with the what bleeding that happens after hemorrhoids from bleeding from piles, and that has to be differentiated from the presence of clots which may be there, which would suggest that there is some bleeding a little bit more proximal within the rectum. If stools are mixed with blood, then it would mean that the bleeding is actually from more proximal, a part of the colon probably, and that is how we would differentiate the level at which the bleeding is happening. Now this can be ascertained from the history, and on clinical examination it is important to also examine the abdomen, because the abdominal examination might reveal tenderness in the left iliac fossa, which might signify some form of inflammatory bowel disease, or in any other area of the abdomen, which normally would not happen if it is exclusively hemorrhoids. So these are things in the history that in your practice that we can, which will help you to differentiate from an intestinal cause for bleeding from an anal cause of bleeding.
Excellent, Dr. Rajshekhar. So friends, to summarize, it's a painless bleeding, like a splash in the pan, fresh blood. If it is painful, then it is either not uncomplicated hemorrhoid, because pain does not occur in the uncomplicated hemorrhoid. It is either a fissure or it's a complicated hemorrhoid. So when you retract the buttock, you can see if it's a complicated thrombus, prolapse, pile, or etc. You can see it over there. So otherwise you can rule out. And the most important danger sign is to miss a carcinoma in this kind of patients. So anybody who's got a symptoms of weight loss, change in bowel habits, or a lot of mucus being passed, all those, and with a family history of cancer in the rectum or colon, they should alert you. This patient needs further reference to a surgical clinic rather than postpone their treatment by some pilex, etc. So coming to the treatment now, after having established that it would be piles, etc., can you tell me what role is played by the general lifestyle modification or dietary changes and how you should do it. Madam, you can take this.
Thank you, sir. So basically, the most important part of treatment is a lifestyle modification, and mainly in the form of dietary changes. And what kind of diet is a diet that is very rich in fiber, means at least 25 to 30 grams of fiber per day is the basic necessity. And this can prevent a bleeding from the hemorrhoid. So the initial stages of hemorrhoids, which are not symptomatic, can be managed very well with a lifestyle modification. That is a good amount of fiber and a good amount of water. So this can increase the roughage in the stools. And when this hard stools, reduce, and this reduces the pressure on these hemorrhoids and can prevent from bleeding. That's the most important
Absolutely.
change they have to do.
Yeah. So friends, lifestyle modification and dietary fiber changes are required in all grades of hemorrhoid. That is why I asked this question first as a general thing. And to apart from the high fiber diet and the enough of fluid, because only high fiber diet does not help. It will make your stool further dry. So you need to take adequate water. And how much water should a patient take? It is 1 liter per 20 kg body weight, provided your kidneys and hearts are functioning appropriately. So depending upon that, you must also advise that they take adequate liquids, whether it is water or some other liquid, they should take proper liquids. What about laxatives, Prashant? Which laxatives do you recommend to your patients with hemorrhoids?
Yeah, basically, we should ask for the history of constipation. If the patient is constipated, and considering the age of the patient, whether in old age, particularly the fiber is needed, and that old age patients, they are unable to chew the fruits. So we have to add fiber to them. If the patient is young, then Dufalac or the osmotic diuretic, osmotic laxatives, they can be added. So that is more important. And one more important thing, if the patient is bleeding, please ask for the history of any anticoagulation, and if the patient is on any blood thinners, so that should be stopped. Or if the patient is under cardiological care, so we should refer to them whether that drug can be stopped or not.
Fine.
So regarding laxatives,
Ah.
basically two laxatives, the fiber and the osmotic laxatives. The fiber should be given in older age, and the osmotic laxative should be given in younger age.
Fine. Kamal, you would like to add or differ or agree?
No, I think what Dr. Prashant has said is absolutely right. Osmotic laxatives are better for constipation as such as compared to stimulant, and I think lactulose or polyethylene glycol, they can be used.
Any experience with the latest drugs like prucalopride, etc., especially in the older age group with diabetic, etc.?
Yeah, older age with diabetes, and I think it has got a very good role. We are giving 1 gram to start with, or the highest dose can be given as a 2 gram per day, and results are really good.
2 milligram.
2 milligram per day.
Yeah, fine. So thereafter comes the definitive line of treatment, and that ranges from either conservative therapy to pharmacological agents, some kind of office procedure in grade 1 and 2, or surgery in the remaining. Given the polysymptomatic nature of the disease, it is difficult to effectively judge which treatment option would be best for your patient. And to top, there are always more new recent advances getting added to this treatment. They are usually simpler than what the other methods were, and with a better post-operative compliance and lesser complication comparatively, allowing you to return early to your normal work. However, will they become gold standard? We still don't know, and let's see what our panelists has to say. So, Rajshekhar, in the grade 1 and 2 hemorrhoids, which we talked about, one, those remain inside and those which come out and goes on its own inside. If the patient is symptomatic, whether they have got bleeding or they have got some kind of discharge, and because of the discharge, some itching, what would you recommend? Have you used medical therapy in the form of tablets which are available or some kind of ointments which are available? What is your experience about that?
The majority of the patients with first and second degree hemorrhoids can be managed conservatively, and my experience has been that I advise them on lifestyle changes. I advise them on dietary modifications if I find there is something abnormal in their diet. And I use calcium dorbicillate. Sometimes I use venoactive agents like Jaflon, and these are drugs that I've been using, and I find that amongst majority of the patients, the symptoms settle down with change in the diet. Now, coming to the agents that we apply locally, I usually prescribe agent which contains either calcium dorbicillate or the one that you've shown on the right side, Euphoria prostatica. We've used both these agents and I found no difference between them. They're both equally good, but majority do not require an intervention from our side. It is only about dietary modifications and taking medications and using some local applications. I have not used, yes, sir.
No, continue. I thought you finished.
No, sir. I have not used infrared coagulation, though I have used in patients with persistent bleeding the Barron's band applicator, and that can be done as an office procedure. And we can control bleeding in grade 1 and grade 2 hemorrhoids by just using rubber band ligation.
Kamal, what advice would you give to our delegates who are logged in today? Which tablets do you think is the most effective? Whether it is any, whether first of all, pharmacological agents have got any role, and if at all, which one is the most effective so far?
Yeah, actually, flavonoids, they are supposed to play a very good role, and that is micronized purified flavonoid fractional. Now, this was basically used for varicose veins, but later on they found that it has got a very important role as a phlebotonic in, hemorrhoids also. So the basic principle is to increase the venous tone and decrease the lymphatic edema. So Deflon initially in grade 1 to grade 2 can be used. And the dosage should be 1 gram, not 500 milligram, which was recommended earlier. Or maybe some people do like to give 500 mg BD, but I think it is recommended 1 gram per day, at least for 2 months.
Fine.
And then topical, okay.
Yeah, topical. Yeah, I was coming to you for the topical. You can see the picture down there. A patient has been using this steroid-based topical creams, and they make their skin very hypersensitive. It becomes red, and when you need to operate upon them, healing becomes a big problem in all these patients. So one should avoid the topical cream because there is no literature to suggest that they are of any use. And medicines in the form of macronized flavonoids, etc., can be used with some success, though the robust evidence is still lacking upon them. Prashant, what do you do when you get, apart from those lifestyle changes and other things, if a patient continues to bleed and come to you, what definitive treatment for grade 2 would you prefer in your clinic?
So if the patient doesn't respond to the primary treatment or the conservative treatment, patient should be advised surgery.
You don't go for office procedures in grade 1 and 2?
We should discuss with the success of each procedure and let the patient decide which procedure he has to go. There are 2-3 dilemmas here. The patient wants to cure, patient wants a cure. Nobody can give 100% cure. That is one. How many hours or how many days of loss of work patient has to undergo, that is also very important. That also can select the procedure. So we have to discuss the various pros and cons of all the procedures, and then we can decide which procedure patient needs, and then that procedure should be.
Right. Madam, could you elaborate in grade 1 and 2 hemorrhoid? What is the practice in your hospital? What do you recommend to your patients? I'm talking specifically for grade 1 and 2 hemorrhoids.
Yes, sir. If they are symptomatic and if they continue to bleed, even we don't believe in any kind of medications or topical applications. We prefer surgery. We give them the option of hemorrhoidopexy for them, stapler hemorrhoidopexy, or open surgery itself. And as sir was telling, band ligation, yes, we sometimes do advise And very rarely, when I don't do it very commonly, though I have done in a few cases, but preferably I would advise them stapler or an open hemorrhoidectomy.
Kamal, I am not very satisfied. Would you elaborate again?
Dr. Naranjan, I think you asked for grade 1 and grade 2.
Repeatedly I've been saying for that.
In my opinion, staplers have no role, laser have no role until and unless it is a failed medical management in grade 2. But very specifically, I would like to say, grade 1, just choose any office procedure as per practice parameters of American College, and it is the level of evidence is 1A. That is very strong. And we can choose any of the procedures, either IRC or we can choose sclerotherapy or bandage.
So I would like to go back to this slide where I had produced all these pictures for grade 1 and 2, which are smaller hemorrhoids, and they can be easily tackled in your office using one of those methods like sclerotherapy, banding, IRC, or the bipolar coagulator, etc., which have got lesser amount of complications. And if you do a proper lifestyle modification and do this definite treatment, then probably the further ascent of this patient to grade 3 and 4 can be stopped. But however, if they go further, become 3 or 4, or they remain 2 and fail, continues to bleed, that is the time when probably surgery is indicated. Coming to grade 3 and 4 hemorrhoids, we have options of open surgery, which we normally used to from last more than a century now. We have an option of arterial Doppler guided hemorrhoidal artery ligations. We have got MIPH, or the stapler hemorrhoidopexy as we call it, and the laser nowadays. So these are the options which are available with us. Prashant, now you can tell me which out of this will you, Prashant, are you listening?
Just my battery is going down. You can ask this question.
And then you can join in.
Yes.
So Rajshekhar, which of these 4 would you recommend to your patient in grade 3 and 4?
Sir, my experience has been that with doing conventional surgery. I do surgery and I prefer a closed hemorrhoidectomy. That's what I've been practicing in an occasional patient. In the earlier days of the stapled hemorrhoidopexy, we used to do stapling. Now I reserve the stapler for patients who come with bleeding due to varices, and I'm not using hemorrhoidal stapler for conventional hemorrhoids at all. I have not used the other Doppler hemorrhoidal artery ligation technique. I do not have the equipment for that. And I've not been using the ultrasession, though we have it here. Because of cost constraints, we don't use the ultrasession for hemorrhoids. Occasionally, we do combine bipolar with the open or closed hemorrhoidectomy.
Hello.
That's what I've been practicing. And it's been...
Madam, would you like to elaborate what is the practice in your hospital regarding grade 3 and 4? Which procedure do you prefer and why?
Okay.
So grade 3 and 4, usually I prefer open hemorrhoidectomy. Earlier, I used to do a lot of stapler hemorrhoidopexy. Then I realized for the grade 4 especially, the results are not very pleasing. And so now I give an option of both, though I say first preferred will be an open hemorrhoidectomy. I do an open method. And I also add a lateral sphincterotomy for them for the pain to reduce. But hemorrhoidopexy, again, I now reserve only for a few patients when there are circumferential hemorrhoids, and giving them an option that it may recur, and explaining to them in detail. But I still prefer an open hemorrhoidectomy as of now.
Prashant, are you recharged?
Yes.
Okay.
Yeah. I totally agree with Madam that grade 4 hemorrhoids, we should go in for open hemorrhoidectomy, Milligan-Morgan. We can convert it to the Ferguson also by doing some closed maneuver. But definitely stapler hemorrhoidopexy is not so good, particularly in not so expert surgeons. So if the patient persists with that idea, then he should have some assistance.
Kamal?
Yeah.
You've got a huge experience with the minimal invasive proctology techniques. What is your say on what our earlier panelists have said?
Yeah, actually, Dr. Naranjan, what I have realized over the years, gradually we are shifting towards minimal invasive surgery. And when we talk about staplers or we talk about lasers, it means we are shifting to minimal invasive proctology. Now, of course, Milligan-Morgan remains a gold standard. It's a time-tested procedure, but we should not forget that when Milligan-Morgan was invented, people did not know about anal cushion. The procedure was in 1937. Anal cushion theory came in 1975. So nobody knew they were cutting anal cushions at that time. Secondly, we should accept it that with Milligan-Morgan, always two problems are there. Number one is a raw area which is created, and second is pain. So in case we can provide any minimal invasive procedure to the patient, I think that is the best. Now, same thing happened with laparoscopy also. Initially, laparoscopy, cholecystectomy, open had very good results, but gradually we shifted to, instead of open, we shifted to laparoscopy. Same thing happened with endovenous laser ablation for varicose veins. So there is no harm in trying, minimal invasive procedures now.
Fine. So friends, the take home message for all of you is grade 3 hemorrhoids and grade 4 hemorrhoids are those hemorrhoids which prolapse and has to be pushed inside, or those which remain outside. Coming to the last one first, that is the complicated or those which remain outside. The literature is very clear that it is the old Milligan-Morgan or Ferguson method which gives the best result, though the short-term disadvantages of wound, pain, the requirement of dressing, and long leave from office are all associated with that, but the long-term results of in far as recurrences are concerned, they are best with open hemorrhoidectomy in grade 4. However, what in grade 3, what Kamal is talking holds true, where when you do a stapler hematopaxy, you do a Doppler guided hemorrhoidal artery ligations, or you do a laser hemorrhoidoplasty, the recurrence rates are slightly higher compared to your open surgery, but then the added short-term advantages are too huge to be neglected completely, such as minimal pain, early return to work, not needing longer hospitalizations. So you need to discuss with your patient, as all of my panelists have been saying, discuss, place the menu card in front of them. Your hemorrhoid is grade this, these are the options available, these are the advantage of this option, and these are the disadvantage of this option, and let him make a choice out of it. We get in, especially in the cities, we get a lot of office goers nowadays, young people who cannot take long leaves and they want to return back to work, or they cannot bear pain and there is nobody at home to do dressing, wife is also working. In those cases, you can offer them minimally invasive proctology. The incidence of recurrences are into less than, the difference is less than 10 to be very specific. With the open hemorrhoidectomy, you can say 92 to 94% cure rate, and with laser or with stapler, it is around 88 to 90. So it's not a great difference, especially in grade 3 hemorrhoid. So whenever your patient asks you कि मेरे surgeon ने बोला है कि ये कराओ ये नहीं कराओ, and you are supposed to guide them, you can also guide them that minimal invasive procedure for grade 3 can be done, provided you are ready for those slightly extra recurrence rates. And grade 4, if somebody has told them go for this thing, tell them that the recurrence rate would be more. One more question is, in pregnancy or portal hypertension, madam, what would you advise your patient? You may be getting a lot of pregnant women with hemorrhoids,
Yes, yes, sir. I basically advise them, again, lifestyle modification, and I follow them up. I ask them to come for a follow-up. The subsequent follow-up, if they still persistently have huge hemorrhoids, I go in for surgery. Otherwise, most of them, if you see, by the end of, after their delivery, and when they come to a follow-up after a month or two, definitely they are reduced. But sometimes they do come with the prolapsed hemorrhoids during pregnancy. So that's the time when I give a conservative management to them and advise them to come back later after delivery. By then, their size reduces.
You around?
If it still persists, then I go in for surgery.
So, at which trimester do you operate, ma'am?
Sir, usually till now, I mean, I avoid surgeries during their pregnancies unless they are bleeding heavily. Probably I have not encountered, they've all done well with my conservative management, but otherwise I would prefer a rubber band ligation as an emergency treatment. Hello.
Ma'am, sorry we missed, or I don't know whether my signal was poor and I only missed. You were saying something which I could not hear.
Sir,
Kannan,
during
everybody else could hear, Kannan?
Sir, you have missed it, sir. Just your
Your
signal is weak,
connection,
sir.
Niranjan
So
sir, your
I
connection.
summarize it in in pregnant females, conservative management is the management of choice.
Yes.
One can use micronized purified flavonoids in the second trimester onwards, and majority of the patient with reassurance and conservative manage, we should pull them as far as possible,
Yes.
because after delivery mostly they would revert back to their normal positions.
Absolutely.
And if it so happens that surgery is required and they become complicated, you are bound to do in surgery, then surgery can be done in the third trimester under local anesthesia in the left lateral position. You can do the surgery for this kind of patients.
Sir,
So
we are having, sorry for the interruption, we are having another 5 minutes, sir.
yeah, thank you so much. There are just few slides which I would show. These are some external thrombos slide. There is a one single hemorrhoid which is prolapsing external thrombo. It is called external thrombos hemorrhoids. Any treatment for this, Kamal? For this?
Actually, Dr. Niranjan, it is called 5 days self-limiting disease. But still, if the patient is symptomatic, we can simply go for excision.
Right. So if it is a small single, like this picture on the left side, you can advise them conservative management in the form of antibiotic. It's a perianal hematoma. These do take time to resolve for at least around 3 weeks, but if the patient's symptoms disappear, you can leave them alone. Otherwise, just under local anesthesia, you can make a nick and evacuate out the clot. The other hemorrhoids, which are all the 3 hemorrhoids are prolapsing out, these are the patient who would actually require some kind of intervention from the patients. These are the complicated hemorrhoids which we just said that surgery is the best choice. And in this kind of a circumferential hemorrhoids, Kamal, you can come here. What would you do in such kind of would you do an open surgery or you do something else?
Yeah, Dr. Nanja, we have got 3 choices over here. The outer part, which is, edematous, we can just try injection hylase in this, because that has got a principle that it increases tissue permeability. The pile mass may reduce. Option is, I think, staplers. Then option is, maybe in case you have done a lot of cases in laser, you can try it. But yes, of course, Milligan-Morgan is a good standard in such cases also.
So if
So you have to preserve the anoderm. There should not be anal stenosis after that.
Yeah, so this is what I was also trying to say, ensure that the intervening bridges of skin in the mucous membrane is preserved when you do a complete excision, because if you don't, this patient will end up into anal stenosis. So with this, my organizers has given me a signal that I must wind it up. So to conclude, obviously there are short-term advantages noted with the newer procedures which we just discussed, and long-term studies are yet required for at least for the laser which has just come in this decade. And whatever intervention is selected for a patient, it should be well discussed with the patient, as Prashant was saying for grade 1 and 2 also. Put it down on paper in this medico-legal world, document it, take the patient's signature that he was offered everything with their pros and cons, and this is what he has chosen. It has to depend upon your expertise, the patient's convenience, and patient's affordability also. With this, I thank all my panelists for their insights into the problem and guiding all of you through it, and the organizers for giving us this opportunity to deliberate in front of you. Thank you so much.
Thank you, sir.
Thank you.
Thank you very much, sir. You are
Thank you, Dr.
excellently,
Kannan.
yeah, sir has excellently moderated everything. In fact, the causes, the types of files and complications of files, and how do you go about, and in what type, how we can manage, everything he has covered within a short time. I thank the moderator, Dr. Niranjan Agrawal, and as well as the eminent panelists for this. And I thank the Natcon 2020 for giving us this opportunity. Thank you once again.
Thank you.
Thank you.
And then,
Yes, sir.
thanks for including us in the panel,
He discussed and then
having this panel discussion.
You add value to it, Rajshekhar.
Huh?
Your presence add values to the panel discussions.
What do you mean, sir? How long?
Yes.
Actually, by 39 minutes, we have finished, sir. Kanagavel,
Kanagavel has
good
come
evening.
in.
Are you on the way?
Yes.
Thank you. Thank you, Dr.
Kanax,
Kanagavel.
unmute, unmute,
Unmute, please.
unmute.
Sir, apart from the discussion, one common advice I give to all patients. Am I audible, sir?
Yes,
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 you are
very
audible.
much.
Yeah. See, waking up early in the morning, clearing the bowel early in the morning between 5 and 7 is very, very important as per the physiology, which people do not do. They wake up at 10 o'clock in the morning. So normally they have constipation. So this is one important advice I give them. Early dinner and early wake up in the morning.
Yes. Point well taken, ma'am.
Thank you, sir. Thank you,
Kanagavel,
Dr. Kanagavel, sir. And he's not audible.
can't hear
Kanax,
you.
unmute, Kanagavel. Voice not clear.
He's traveling, I think.
Yeah, he is coming from Madurai. He is nearby Chennai now. He could not reach before 4. Sir, excellently you have moderated, sir. In fact, you have given a clear-cut message about the complications of hemorrhoids also.
And nice pictures too, sir. Sure, really. Thank you.
Day
Nice
in, day
meeting
out, we are doing only this nowadays. Webinars.
Kanax,
I
your
know, sir.
audio is not clear. It's in
But
fact
we
not
still
audible.
miss the physical meeting, isn't it, sir?
Huh?
We miss meeting each other.
Absolutely. No
Yes,
doubt
yes,
about
Kanax,
it. And as the time passes on
that one
more
time.
longer and longer, it is being missed further and further.
Yes, sir, it's becoming too much.
Sir, okay. Thank you. Okay. Thank you. Sir, Kanak is not able to join, sir. No problem. He's on the way. Thanks each one of us, sir.
So thank him on our behalf to give us this opportunity, and
Yes,
thank
sir.
you for hosting us today. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Thanks to IMA
Have a
also.
nice evening. Bye.
Thank you.
Ma'am, time on it. Actually, correct.